Hi, I'm Ahmad Nazwan, one of the urologists from PPM. So I've been tasked to talk about localized prostate cancer, principles of risk stratification, and treatment selection. So what I'm going to go through is number one, what is localized prostate cancer, the definition, how we stratify the risk, and some brief overview of how we choose treatment. Okay, so let's first start about what is localized prostate cancer. So from the American Joint Committee of Cancer, that's known as AJCC, we know that localized prostate cancer is mainly from T1 to T2 and M0, M0. As per most guidelines, including AAU, T stage should be based on clinical digital rectal exam. So any different T stage found on MRI or PET scan should be noted, but shouldn't exactly change the risk stratification. However, ABA has proposed a new TNM incorporating MI-TNM to incorporate the findings of MRI and PET scan into staging. Okay, so now we're going to briefly go into risk stratification. Since D'Amico and team first started the risk stratification tool for prostate cancer localized, a lot of other tools have come out. Okay. As you know, D'Amico was used to show the risk of biochemical recurrence post-treatment. Other tools quite commonly used are EAU, which is very similar to D'Amico, NICE, UROC, AUA, and CCN, as well as CPG, the Cambridge Prognostic Group. And there are also nomograms. Most famous is the MSKCC, as well as the Kappa score. So this is a study done by Zelig et al. Looking at the different tools and nomogram to see which can predict cancer-specific mortality better. So you can see from the graph, the one with the highest concordant index is the MSKCC Kappa nomograms, as well as the Cambridge Prognostic Group score. Okay, so whilst surprisingly, although everybody uses it, EU and D'Amico are actually at the bottom. Looking at that, that's why EU have actually updated their risk stratification tool to actually divide the intermediate risk into favorable and unfavorable based on the criteria shown there. And this actually makes it more similar to the Cambridge Prognostic Group score. So this is that is actually listed in the latest EU guidelines and what we mostly use. So based on T stage, ISUP grade, as well as PSA level, we can divide into these risk categories. And of course, the higher the risk of recurrence post-treatment. Okay, there's a growing interest in the use of biomarkers to help with risk stratification. I think most of us will be quite familiar with Oncotype DX, which is used in other cancers. And there are two that are quite specific to prostate cancer, the Polaris as well as the DEXIPER score. So this all has been shown to help predict biochemical recurrence, metastasis, prostate cancer specific mortality, and for the DEXIPER score can even help to predict conversion from active surveillance to definitive treatment. However, this should be used sparingly, not for all patients. For example, AUA recommendation is to use for high volume ISUP1 to decide whether you should stay in active surveillance or not, and also for favorable intermediate risk who may be keen for active surveillance. So then is it a good idea for them to go for active surveillance or not? So regarding BRCA, we know there's an association between BRCA and prostate cancer, but for localized disease, it's advised to only do BRCA testing if BRCA is actually present on the biopsy. And also in cases where someone has multiple family members aged less than 60 with prostate cancer, or has a family member aged less than 60 who actually died of prostate cancer. Regarding urobiomarkers, there are a lot that are being studied. The graph shows the study by Ola et al. Showing the addition of 3 novel biomarkers could actually improve the prediction of progression-free survival in high-risk D'Amico or Cambridge score 5 patients. Okay, lastly, we're going to talk briefly about how to choose treatment. Of course, I'm not going to go into details regarding treatment because I think this will be covered by the other lectures like Dr. Sandhya and Popong. Okay, so for low risk, Okay, whether this is low risk according to the AUU. So the best option is if the patient has a good life expectancy, is active surveillance. Okay. Alternatively, if the patient has a limited life expectancy, then you go for watchful waiting. Okay. Of course, this is guidelines. There are still some patients who may actually say they want to do other active treatment like radical prostatectomy or radiotherapy. So all comes down to shared decision making. So regarding favorable intermediate risk, options after shared decision making with patient are mainly active surveillance, radiation therapy, or radical prostatectomy. Regarding active surveillance, criteria include low disease extent on MRI, low biopsy extent, meaning that 3 or less cores have a pattern 4, uh, less than 50% core involvement or overall cancer involvement, and less than 10% should have, or the core should have less pattern 4. Okay. And ideally, the PSA also should be less than 10, if not less than 20. Regarding radiotherapy, options include brachytherapy. You can also do SBRT, or you can do the intensity modulated radiotherapy. Okay, and usually this is in conjunction with 4 to 6 months of ADT treatment. Okay. Regarding prostatectomy, options include open laparoscopic or robotic to remove the tumor, and usually in this stage, we not necessary to do a pelvic lymph node dissection. Okay. Regarding ablation, uh, still no long-term data in more than 50 years to conclude. So both AUA guidelines as well as EU guidelines cannot say that it's a mainstream treatment at the moment, but EU guidelines say that you can do it part of a clinical trial or part of a clinical registry. Okay, regarding unfavorable, intermediate, and high-risk patients, the options are largely divided between EBRT plus 18 to 24 months of ADT or radical prostatectomy. This can be, as mentioned, whether you want to do open or robotic, but the decision of whether you should do pelvic lymph node is still debatable. So some will say that if you have more than 8% score on the Amsterdam, Brisbane, Sydney mammogram, that you should do pelvic lymph node dissection. Okay. For some patients who are not really fit for surgery and have or radiotherapy and have a doubling time of PSA doubling time of less than 12 months, plus a PSA more than 50 with Gleason 5, you may opt for palliative ADT. Okay, but guidelines are guidelines. In the end, there are a lot of other factors that determine whether patient go for which course of treatment. This includes patient's own anxiety. Okay, those who are anxious are quite unlikely to like active surveillance. Their own choice, tolerance of potential side effects, particularly very significant ones like incontinence, risk stratification, that's what we've been talking about, fitness for general anesthesia, as well as logistics. For example, some people may have difficulty coming for the daily radiation required by EBRT. Okay, so only once you put all these factors together, then only you can come across for the actual treatment decision. Okay, with that, I thank you and hope to see you for the physical meeting soon.